in the last few minutes, I wanted to switch gears one more time to biomarkers, because I think, you know, as we see this portfolio expand of different treatment options, ideally, we'd like to be more precise in our patient selection. Prognostic factors are one thing, predictive factors are another, and developing, you know, biomarkers that can help us predict for that clinical benefit is key. Sarcomatoid elements is one, and that may not be a sexy new one, but it does seem to be a negative prognostic factor, but a positive predictive factor.
For IO.
Yeah, so, but what about PD-L1 status? We talked a little bit about that in addition to sarcomatoid. Are there other settings where we're using PD-L1 status in renal cell?
So I think that PD-L1 status is still fairly controversial as a biomarker within RCC. You know, certainly in Checkmate 214, they showed the associations with higher PD-1 status, like being associated with better responses. But for the TKI-IO combinations, it has not been as well predictive. So I think that the jury's still out in that sort of setting, and especially with that many different PD-1 assays that we could use, whether or not we're looking at the tumor itself, whether or not we're looking at the immune cells, whether or not it's a combined score, you know, what the cutoff should be. Like, I think those are things that still need to be worked out. And it doesn't seem like, you know, the cutoffs that were used in other disease groups, you know, are directly translatable to RCC.
Right. I mean, if you look at the Checkmate 025, the Javelin 101, and even Cabozun, their primary endpoints were met with progression-free survival and overall survival, irrespective of the PD-L1 status. And, you know, I think that when Atezo-Bev came out and we sort of looked at that data that Dave McDermott presented 3 years ago, we felt as if our patients with PD-L1 would thrive on these targeted immunotherapies. And we're just seeing that it sort of makes us a little bit more excited, but it doesn't make us feel as if that is our biomarker of choice.
I think it's fair to say that in renal cell carcinoma, at least PD-L1 as just a single biomarker is not there to really select therapy. I think it is prognostic definitely for patients who are treated with TKIs alone. We know that data that tumors that are PD-L1 positive, those patients don't do well at all with TKIs monotherapy. I think there is definitely a higher response rate in patients who receive immune checkpoint inhibitors if their tumors are PD-L1 positive, but you do get benefit in patients with PD-L1 negative, and that's the Keynote 426, that's Checkmate 214. All those phase 3 trials have shown a benefit for both you know, the groups, PD-L1 positive and PD-L1 negative. So I'm not sure we're there. I mean, the jury's still out for what is the best biomarker, if there is any biomarker to really help us predict. Now, there was an abstract presented yesterday, Friday morning, actually, in the Clinical Science Symposium on the Javelin 101 phase 3 trial, looking at predictive biomarkers. Interesting data. I mean, it shows that you could do it. Industry can, you know, do whole exome sequencing and RNA-seq on 700 patients. But I think, what do we do with this data? Because it's specific to a regimen. And if you do the same thing for Emotion 151 or for you know, Javelin 101 or for Checkmate 214, we'll come up with a different signature of genes that predict to response. So I really don't think, the jury's still out, I really don't think we are there to really you know, use this data in the clinic for you know, for our patients. The biomarker that I'm really interested in, that I think we should have, is, again, we talked about some of the challenging toxicities of these patients treated with immune checkpoint inhibitors. Can we predict, before we give a patient an immune checkpoint inhibitor, who's going to get this you know, bad, severe toxicity? Because I think this is really important, to spare that patient the horrendous toxicity if we knew beforehand that they have a polymorphism or something that predicts for really a bad outcome.
Some small antibody load for, you know, muscle antibodies or something like this, myasthenias. I mean, we've seen some of these really severe cases and gone back and looked at blood and found, yeah, there was a small level of, you know, antibody present. Yeah. I think that's a good point. I am glad to see that our clinical trials are including more of this prospective collection of tissue and blood to look at these for these predictive markers. I do think we need to get there. I agree with you. I don't think they're ready for prime time, but you know, it's high time that we started building these kind of prospectively into our trials.
Yeah, no, I completely agree. I think it's very important that we incorporate these biomarkers and further this development because with so many options, we can't run a large phase 3 of every single permutation. We're going to have to really let some of the science guide us in terms of what we do and how we stratify.
Yeah, and I think the last thing, we're here at ASCO, care for every patient, learn from every patient. I mean, I think there's going to be need for some registry type work where we're getting some real world data on patients and maybe some imaging and blood collections on patients. And
Dan, you're doing that at Duke.
Yeah,
can
we're
you tell us about
planning something like this.
Yeah.
A large, probably, electronic health record-based prospective cohort study to look at both academic and community centers at outcomes in patients with metastatic renal cell carcinoma, collecting baseline blood samples, an imaging repository, and a tissue repository. It's a big, long effort, but I think these are the kind of things that can really confirm and corroborate some of the markers that may evolve in the future, maybe find that common marker across studies that we're looking for, and things like that. So, I think a lot more work to be done. Exciting times in the field. The plot only thickens